My name's Alex. I'm coming to you from Brooklyn, New York, the unceded lands of the Lenni Lenape people and the Canarsie peoples. It's good to be here. I get to talk with you today about therapy and how to facilitate psychedelic experiences and psychedelic treatments. I'm excited to talk about EMBARK, which is a new approach for the whole person that attempts to psychedelic work. We are attempting to look at all of the sort of shortfalls in existing therapeutic approaches to psychedelic medicine and to conceive of an integrative psychology, an integrative approach to doing this work that has been used in clinical trials for which there's an emerging evidence base, and also, frankly, an approach that clinicians like using and that feels aligned with your clinical judgment and skill and your work with patients. Like Lika said, I'm a psychologist based out of New York. The reason I started getting into psychedelic research and going to conferences and hosting conferences over 20 years ago. My background is really in psilocybin research. I was a founder at New York University of a team where the team's done incredible work looking at psilocybin-assisted psychotherapy as a treatment for cancer distress, depression, anxiety, alcohol use disorder. And I know there's a multi-site trial in Finland for the treatment of alcohol use disorder. Also with healthy, normal people who are religious leaders and spiritual leaders. I've also done psilocybin work to treat OCD through a trial where I'm a co-investigator at Yale University. And I've done work with EMBARK at Cybin, formerly as their chief clinical officer, and now as a consultant and teacher. And I teach in a variety of different psychedelic training programs. I'd like to share my screen now. We're really excited, and I'll return to this, really excited to share that, what I'll be talking about today, the EMBARK approach to psychedelic therapy, is coming out as a book published by Oxford University Press. It's coming out in a couple of months in April, and it's written by my dear friend and colleague, Bill Brennan, and myself. So here's a picture of the cover of the book. I'm going to be walking through a rationale for this approach for EMBARK. We have some lovely blurbs from people like Roz Watts, Rick Doblin, and Jeffrey Gus on the right. So I'm excited to talk a little bit about this approach. And if you're interested in the book, you can pre-order on, from the press itself or from Amazon or other booksellers. I do want to just disclose all of my funding sources for the last 3 years. So I've been teaching in different university and training programs for psychedelics. So I think I've listed them all here. If you have any questions about that, please go ahead and let me know. I'd like to take the first, hour today and just sort of walk through a little bit of like the quick intro to something that you probably already know, which is like, wow, we are really, really in an incredible time. From a psychiatric history, psychological history point of view, rarely have we seen such an explosion of a completely different modality of treatment, which is the re-emergence, sometimes called the renaissance of psychedelic therapy. And it's not for no reason. I'm going to be showing you 13, this is the first quotation from patients that I have worked with and interviewed in depth. So my passion is in psychotherapy, but I also have a passion for qualitative research and in-depth interviews. And these are quotations about what it's like to take psilocybin in our trials in New York City. And these are patients in those trials who have cancer, anxiety, and depression. So it's unlike most treatments for anxiety and depression. This person says, I felt completely at peace and whole and loved. I felt so loved and understood and forgiving. The 12th person I interviewed said, I can go into myself and find peace and comfort. It's there. So I am changed by this, and in pretty significant ways. The 11th person I spoke with said, I felt connected to myself. I felt more self-love and a feeling of love for humanity very deeply. It's the first time I ever really felt like I was part of the world instead of separate from it. The 10th person said, this was an incredible woman that I got to know. She was so enthusiastic. She said, it's there. It's there. Looking into a flower, it's there. Watching a praying mantis move its tentacles, it's there. That the one is anytime and all the time. It's all the time. It's always there. It's like, it's almost made me feel stupid. Like, hello, wake up. It's like waking up in the most profound way. That this is really what life is. It's really like this. We're just not noticing. The 9th participant said, I felt bathed in universal love. It was such a strong feeling. The 8th person said, as a young man who was dealing with cancer recurrence, from when I was 17 until I did this psilocybin study at NYU when I was 24 years old, my spiritual life was dormant. I was going to say dead, but just dormant. It was non-existent. And this not only stirred that back up, it reassured me beyond doubt that there is a spiritual realm and I need to be aware of it. It is an important part of my existence. What about anxiety? This person said, I have a restored ease with life. The percentage of my life that I am able to be present in just a moment has increased dramatically. This person had a vision with the psilocybin. She said that I felt like that was my umbilical cord from when she was born, my umbilical cord to the universe. And she was reckoning with her own death. I felt that this was where my life would be drained from me someday. And I would surrender it willingly when my time came. And that was just so profound. And then also that, and I started hearing. I chose this, knowing how my life would end, knowing how it would end. This person was a little bit more cynical about the spiritual aspect, but she did have a vision of soaring in a cathedral, in the Gaudy Cathedral. I really was soaring in a cathedral, she said. It's amazing, but I spent a lot of time floating up around those spires with the music, with certain music, and that was really incredible because I think that became apparent to me. But as much as it was wonderful, uplifting, and spiritual and God-like, I really wanted to be flat on the ground, you know? I'm up there with God, but I want to be in the trenches. I want to be that doing person, not a complete spiritual in the clouds person. And in her integration from the psychedelic work, she went about making changes in her life in the days and weeks after the treatment session with psilocybin. This person felt gratitude. He said, I felt a kind of joy and sorrow all at once. It probably looked more like sorrow, but sorrow has never been so beautiful because it is indescribable, because it's of the highest calling, gratitude, gratitude for life. This young person said, how do you explain infinity? It really pushes out the boundaries of our understanding of what medical treatment can look like. Because he said, what do I tell you? What word do you want me to use to explain infinity? Because that is what I am feeling. I am experiencing infinity. This person, again, this is in a cancer trial dealing with depression and fear of death. She said, you just see with your own eyes that that's what happens after you lose your body, and there is nothing to be afraid of. So people are engaged in a deep meaning making process with their therapy team. And then lastly, moving out of the cognitive into like the heart, into the place of feeling. This man said, my heart was an energetic field that I was able to work with. There was no sense of theoretical mental gymnastics. It was all in the realm of the heart, and that's where the whole thing took place. So as the person who was interviewing these human beings, I was so moved to speak with them. And I was deeply, about half of them started to cry with me when I was asking them about their experiences. And so I just wanted to bring in the voices of the people who are actually in these trials doing the hard work of changing, confronting themselves, honor their therapeutic experience, confronting the psychedelic experience with psilocybin and other medicines and other compounds that are being tested. It's not an easy job, but it does point the way to what we see in the research literature, which is just a true explosion of scholarly interest. When we started the team at NYU in 2006, there weren't any other teams that were formed except for UCLA and Hopkins. I think Imperial got started a little bit after us, and there's just been a gigantic explosion, the geometric expansion and the number of journal articles that are published that far exceeds what we saw in the 1960s and 70s. And we see the number of clinical trials, and these data are already woefully out of whack, geometrically expanding. This is in Nature. And the reason is that there's just such high efficacy rates, such high response and remission rates. This is depression remission in my trial, our trial from New York University, with Steve Ross as the PI. And we just see over 80% of participants having remission, absence of depression after treatment with psilocybin, and it's not just psilocybin, it's psilocybin-assisted psychotherapy in this trial, a very intense period of preparation and integration before, during, and after. And this is a between-group analysis looking at the group that got psilocybin and psychotherapy in the purple versus those that got just the placebo alone. And the Cohen-D effect sizes are very large in these trials, oftentimes of very large magnitude, greater than 0.8, which means that they're oftentimes 3, 4, 5 times more power, more of an effect size than SSRIs or SNRIs, standard treatments for pharmacotherapeutic treatments for depression, for example. So there's very exciting data that are coming out. This is from Lancet Psychiatry, treatment of depression, individual trajectories from Robin Carhart Harris's work that was followed up in a direct comparative trial between psilocybin in the treatment of depression versus escitalopram. And it's just, I think that the data suggests that the next generation of psychiatric and psychological treatments will be led by more efficacious treatments with psychedelics than with existing classes of medicine. And we're seeing that in a massive influx of billions of dollars into the psychedelic industry. We're seeing that with many hundreds of clinical trials being registered around the world. So I'm going to switch over just to another share for a second. If I go to here and I go to, yeah. So what I really want to talk about today, though, is Oh, that's not what I want. I want to do this one. What about the therapy? So I'm passionate about psychotherapy. I imagine many people in the audience are interested in what are we talking about? Like, what's the human element of this? We know that in indigenous lineages, in underground settings, in naturalistic settings, in psychotherapy clinical trials, there's a very strong sociocultural context, oftentimes administered through psychotherapy. Here I have a little word cloud of all the different words that in our recent meta-analytic review, we took a look at all of the different psychedelic therapy approaches that have been published on, and people call it many different things. Sometimes we call it psychotherapy, PAP, psychedelic-assisted psychotherapy, PAT, psychedelic-assisted therapy, psychedelic therapy. There's also the idea that it could be administered by paraprofessionals who are not licensed psychotherapists, and oftentimes it's called support, so psychological support. Sometimes it's a support meeting or just a psychosocial intervention. Sometimes it's called psychoeducation. Sometimes it's called integration or integrative psychotherapy. Sometimes it's, there's all sorts of different names that are being used for it. We wanted to take a look in developing a new psychotherapy. The question is, what is really the best way in this cultural context to do psychedelic work? What therapy should be used? And here's the first of 2 pages of tables. Here's the first page. Here's the second page. So these are all of the clinical trials of psychedelic medicines for psychiatric indications. Most of them are with psilocybin. Many of them are with MDMA. I worked, by the way, as an MDMA therapist for MAPS on a MAPS trials for many years, and started a nonprofit organization in New York to do MDMA research. So I'm familiar with those protocols. I've also done ketamine research and DMT clinical trials. So I have some background in a variety of these approaches. And what we wanted to study was, okay, let's look at all of the existing psychotherapy approaches and see what are the psychotherapies that are being used. One of the things we wanted to do was to see what was being reported versus what was being missed. And we did an analytic review, and in our meta-analysis of 33 published clinical trials, we found that many of these authors actually didn't report, in psychedelic clinical trials, did not report very basic aspects. So, for example, 33%, 1/3, did not report the number of sessions. They would report it was psilocybin, but they wouldn't actually say, well, exactly how many sessions are happening before, during, or after in terms of preparation and integration. 45% did not report the duration. Were the sessions 45 minutes? Were they 90 minutes? Were they a variable length? Who's in the room? 42% did not report the provider credentials. So are they psychiatrists? Are they clinical social workers? Are they psychotherapists? Are they psychologists? Are they trainees? Are they paraprofessionals? Are they peer support? What are the license qualifications? In the United States, for example, I'm a psychologist. In addition to an entire PhD, I have 3,500 hours of clinical work with patients in order to be licensed as a psychotherapist. So, and even a master's level counselor, I mean somebody who has a master's level counseling degree in the United States has 3,000 hours of experience working with patients. So that's 3,000 hours more than somebody who does a 50-hour training in psychedelic support, but otherwise may not have a background in helping professions as a psychotherapist. Of all the 33 trials, about half, 52%, did not report if they used a therapy manual. This is a big controversy. Should the psychedelic therapy be manualized? If it is manualized, how manualized is it? How constraining is it? But you should at least report if you're using a protocol manual, a therapy manual. If you're using a manual, can you make it accessible to readers? Was it available online, or reference a manual that we could actually take a look at so that we understand what does the manual say? And then lastly, if you're doing psychotherapy research, which is an area of specialization that I've done, one of the things you have to do is, what is actually happening in the room? What are the interventions that are happening between the therapist or the facilitator and the participant? And 82% did not report that they assessed what we call treatment fidelity or therapy adherence. That's where you actually go through and you qualitatively code, are the therapy interventions that the therapist is saying, do they match up to what is actually prescribed in the manual? And here's the citation for that. So what therapy should we use? So in all of these different approaches, this is sort of a list of some of the approaches that are being used. A big one started with MAPS calling their work non-directive psychotherapy, which they later amended to inner-directed work. I was trained by Michael Bogenschutz, and Michael Bogenschutz is a friend of mine and colleague. The Mythhoffers conducted a training with people in MDMA-assisted therapy in 2016 and in the years thereafter. And the idea with inner-directed work is to encourage the participant to turn inward and let their inner healing intelligence, this idea of an inner healer or an inner intelligence with the MDMA, lead them to what they wanted to work on. You can set an intention, but the therapist's role is to encourage the person to turn inward. One of the therapist's roles is to turn inward and to go into the work. At NYU, and I was trained in a sort of theoretically relational and interpersonal model, people like Jeff Guss, Gita Vaid, Raquel Bennett, and many others embrace a psychodynamic or a relational approach, which is, in the psychedelic work, we want to have we want to recognize that that psychedelics are a non-specific amplifier of relational processes as well, and that they amplify transferential and countertransferential experiences, which is one of the reasons why psychedelic work is so potentially at a risk of harm, which is that ruptures that happen which would normally be minor ruptures on a psychedelic, become amplified into bigger relational ruptures. And so it gets very intense, and there's an opportunity, as I'll talk about with EMBARK in a minute, for relational repatterning. And the interventions between the therapy team and the participant are really important here. And also potentially, the volume is turned up on the ability to leverage the relationship in pursuit of healing, in pursuit of decreasing anxiety symptoms, decreasing depression symptoms. But what about EBTs? What about evidence-based therapies, evidence-based practice? If you're a researcher in the early aughts, 20 years ago, and you're trying to persuade your department chairs and faculty, I want to do research with psilocybin, they're not that excited. They were not, I have to tell you, they were not that excited about that idea. It was a Schedule I drug, an illegal substance. There's not really any money in it. People thought that you were a little bit nutty to want to do that. And so oftentimes I think, this is my opinion, and by the way, everything I'm saying in this talk is my own personal thought, not that of any other organization. But I think it was like, let's study this outlandish, crazy thing, psychedelic medicine, but let's use the most conservative research approaches. So we do double-blind, placebo-controlled randomized trials in an extraordinarily conservative, very scientific and even scientistic way. And also let's use existing EBTs, for example, like CBT or Meta, or an existing therapy intervention that's already tried and true, and then kind of append that to a set and setting style protocol. And this has worked quite well. And Matt Johnson at Hopkins, psilocybin trials for smoking cessation. They use cognitive behavioral therapy in conjunction with sort of work that people like Mary Casamano and Bill Richards at Hopkins do in the room, which is a set and setting sort of supportive model for psychedelic work. But they also pair it with this EBT, where the quit date, to quit smoking, is the CBT dosing date. So you use cognitive and behavioral strategies in conjunction with some psychedelic support. Similarly, motivational interviewing and the Meta approach was used in trials at NYU under the leadership of Dr. Michael Bogenschutz. We also see a tendency to using EBTs like ACT, acceptance and commitment therapy, which highlight meaning and sense making. How do we make meaning of the psychedelic experience? And so with the Hexaflex model, the Yale Manual for Depression with Rob Krauss and Jordan Slowshauer and Jeff Guss really leveraged the Hexaflex model. But in a lot of these clinical trials, they were missing little pieces, or they sort of pull in other things. So there's this idea of pulling in somatic practices, like the body keeps the score, Bessel van der Kolk's work and Pete Levine's work with somatic experiencing. Because when people take psychedelics, they have strong physical experiences. I noticed that with many of the participants I worked with. IFS, internal family systems, has become very popular, especially in the MDMA community. Dick Schwartz's sort of idea of using parts work, borrowed in part, I think, from relational and psychodynamic approaches to understand that what different parts of the participant show up in the room. And then there's like a host of other things that are sort of emergent, and this is not an exhaustive list. And Wagner's work with couples therapy, different modalities doing individual work, but also group work, circle work, which is a traditional way of doing this kind of thing. Annie Leila has talked about family therapy. My friends and colleagues Ingmar and Elizabeth Gorman and Nielsen at Fluence have talked about a trans-theoretical approach to supporting people in the community when they take psychedelics in naturalistic settings and they come into the therapy room and need some support. I'm going to focus on the next half hour really on EMBARK, and I'll be introducing that model, which is something that Bill and I have been working on. So here's a table from one of our papers. I don't think what's important here is just that there's a lot of basic support models that use some sort of psychedelic set and setting approach. And there's also EBT inclusive models that sort of append things like existing therapy approaches, existential approaches, motivational enhancement, ACT. In Brian Anderson's trial, they used something called brief supportive expressive group therapy for a trial of long-term survivors of HIV and AIDS with demoralization, mainly gay men in San Francisco, but I think other folks as well. Roz Watts and Carhart Harris have come up with the ACE model, and Compass and others have turned to something called perceptual control theory. This is all very nice, but I think that we are in a kind of early adolescence in the development of the psychotherapeutic support architectures, models. Like what are the existing models that are not really taken from other literatures, but are actually about the psychedelic space? And we have seen some limitations. These are real challenges to the field. First of all, there's been a lack of attentiveness to the body. Most of these models don't even mention the body or somatic experiencing or emergent somatic processes. And we know that when people are given moderate to high doses of psychedelics, they have shaking, convulsing, they have visions of their body. It's not just happening up here. The entire body is involved. And so you would think that the therapeutic intervention would also attend to the body as a site of healing. A lot of these manuals treat the participant like an object rather than as a subject. And so there's not much attention to the relationship between the therapist and the participant. Whereas when we actually do qualitative work and we talk to patients, they say consistently that the therapeutic relationship was incredibly important to their sense of safety, trust, ability to go deeper, and ability to integrate and heal before and after. I know that this is my understanding is that this may be different in Finland and in European countries, but at least in the United States, a lot of people experience the high-dose psilocybin work as a religious or mystical, spiritual experience. And we know that the mystical experience questionnaire is a statistical mediator of benefit for depression, anxiety, substance use disorders. When people have a mystical type experience, a religious experience, they get better. The facilitator, the therapist in the room, However, in all of those trials, they don't even have like a framing for mystical experience or spiritual counseling experience. So oftentimes psychotherapies, existing psychotherapies, are very secular, which is fine, except when what is emergent for this particular patient is a profound experience of God or of the sacredness of nature or existential encounters with their own death. Then you need to think about what the training framework is. This is very sad and important, but we wanted in building EMBARK to address one limitation, which is the limitation of ethical boundary violations. There have been far too many ethical relational boundary violations with people having sex with research participants, with people, inappropriate touch. Recent allegations have come out with leaders in the field, and in the existing therapies, a lot of the times they'll give a therapy and then they'll just say, and consult your code of ethics as a psychologist, or your code of ethics as a counselor, or your code of ethics as a therapist about what is ethical. We actually wanted to bring ethics right into the center of the psychotherapy and focus on ethics directly. There's a limited conceptualization of who the therapist is and what they do. Are they just delivering an existing modality, like shelling peas out of like a pea pod? Or are they working and generating with the participant new material? And then lastly, look, as I said, most people who do this kind of work as therapists have thousands of hours or many years or decades of experience. If you give them a training and the training is 100 hours or even 200 hours or 50 hours, there's only so much that can be learned in 50 hours, but they have thousands of hours of experience to draw on. And so many people arrive to psychedelic facilitation training as trainees. They come with an expertise in somatic practices, expertise in mindfulness and metacognition and how to meditate, expertise in doing somatically informed work with participants, expertise in emotion-focused therapy, expertise as relational psychoanalysts. How do you leverage and incorporate their existing skill set and acknowledge that they will be using that in the trial? And lastly, how does it work? How do psychedelics work? And there's been I think, a reductivist scientific model that, it's the default mode network, or there's functional neuroconnectivity in different parts of the brain, very biologically based models of 5-HT2A. And all of this may be true. The Rebus model, all of these sorts of the neuroplasticity, the anti-inflammatory hypothesis, all these sort of biophysical models of what happens in the brain can be true, but they don't have much explanatory power for most people. And so we want to look at change mechanisms in addition to biological change mechanisms, look at psychological change mechanisms, the bread and butter of psychotherapy. So I'm going to skip ahead and talk about EMBARK now. And I'm really excited to share it with you. Our intention is that we have learned from so many, despite my loving critique a moment ago of the limitations, I have been trained by many skilled and wise people and have been mentored by many people. And in putting together EMBARK, we really relied and stood on the shoulders of giants in the field. EMBARK was an attempt to create a transdrug, transdiagnostic model, which means it's an approach to psychedelic treatment that can work across drugs, for example, with psilocybin and derivatives, DMT and derivatives, with MDMA, with ketamine, and it can be used transdiagnostically. And so it can be adapted, the EMBARK model can be adapted for a treatment for depression, as Cybin has done. It can be adapted, and we have successful randomized controlled trial data from that trial that Cybin has come out with. It can be adapted for the treatment of burnout and symptoms of depression in doctors and nurses, which Dr. Tony Back has used at the University of Washington in Seattle. And so it can be adapted to treat alcohol use disorder and substance use disorder. And this is based upon, in CBT world, the idea of the unified protocol, the UP, which is the idea that we create a model and then we adapt it for a particular indication, and this is a unified protocol. The idea with EMBARK was to create a sort of unified model to doing psychedelic work for all the different indications, potentially populations and drugs that would be used. So EMBARK is an acronym, EMBARK. And I'm going to go through in depth each of these. But it's built emically from the bottom up, looking at all of the patient experiences in psychedelic trials and what we've learned in leading process evidence and talking with trainers and teachers and senior clinicians in the field. We found that these were the 6 major domains of potential healing. For any one patient, maybe only one domain of healing of these 6 will be important. So for example, one person might have a really profound existential experience about the meaning in their life, or their experience of being alive and confrontation with death, or an experience of a mystical experience. And so the E domain, the existential and spiritual domain, may be ascendant for them in their preparation, medicine work, and integration. The M domain recognizes that we can be mindfully present with whatever comes up and develop and cultivate a non-judgmental, present-focused awareness. The B in EMBARK is for the body aware domain. This is a recognition that the body is a site of healing, it's a site of trauma, and that what we're doing is not merely cognitive alone, but that somatic work arises in therapy practice, and that the clinician should be prepared with some basic competency around body-aware practices. The A in EMBARK stands for affective. These are feelings, affects, and cognitive. So this is all of the work about the sort of cognitive triad of thoughts, feelings, and behaviors that make up a human life. And so here in the affective and cognitive, we only wanted to bring in existing work because when people take psychedelics, when they're given psychedelics in clinical trials, they have all the feelings, lots of affect, very strong feelings in our research. The R domain is the relational domain. So this is suggesting that it's not just a drug and an individual. That individual is not an atomized, alone person. They are part of they are in relationship with the therapists, and they are in relationship with their family and their community. When I interviewed participants in all of these half a dozen trials I've been a researcher in as a qualitative researcher, they consistently talk about their mother, their relationship with their father, their grown children, their ex-girlfriend. These human relationships become very critical, and they seem to be trajectories of healing because people feel regret, they feel forgiveness. And lastly, in EMBARK, the K stands for keeping momentum. We want altered traits, not just altered states of consciousness. And so if you take a high-dose psychedelic work, we want to keep that momentum going. If people feel better in the days and weeks following, how do we get that into a durable benefit over months, 3 months, 6 months, a year? And in a 4-year follow-up study to our NYU study with cancer patients, we see that 4 months later, people still were attributing long-term benefit to their experience. How do we keep that momentum through goal setting and planning and relapse prevention? What about ethics? So here, the EMBARK model has this is the 6 domains, EMBARK, and these are the 4 cornerstones of care. 4 care cornerstones. The 4 cornerstones of care is that we as clinicians strive to provide 4 different types of care when we work with participants. We provide trauma-informed care, culturally competent care, ethically rigorous care, and collective care. So the idea is that we know that even if we're not treating PTSD, post-traumatic stress disorder, that people arrive with relational trauma, lowercase t trauma, and capital T trauma, and we have to be prepared for that in all of these trials. We attend to the relationship. We work deeply to create safety and empowerment through providing as much autonomy and consent to the participant as possible, and restoring their sense of self-regulation and providing aftercare so we don't just drop people at the end of the treatment. What about culture? How do we provide culturally competent care across when you're working with people from a different culture, a different background, a different life experience? When you're a straight researcher and clinician working with a trans client, when you're a Black clinician working with an Arab American participant, how do we attend to our own humility in the face of our privilege? And I have profound privilege I'm a queer researcher, I'm a gay man, and I'm white, cisgender, and have profound privilege because I pass as straight. And so in working with this, how do I attend to my own forms of cultural blind spots, things that I do not know about, and how do I speak about that in the room? In a lot of my research with gay people, for example, in psychedelic trials, a lot of people go into a psychedelic trial and they never tell their therapist that they're gay because they don't feel safe to tell them I'm gay or bisexual or my gender pronouns are, they and them. Oftentimes they don't feel safe enough to do that. So how can we attend to that in the room? What about the issues of boundary violations, inappropriate touch, sexual relationships? This seems to be especially unique in psychedelic-assisted therapy. Participants may become very suggestible. They may have impaired autonomy for the time that they are under the influence of the psychedelic. And it changes the dynamic. So we have to do enhanced procedures for consent, for any sort of touch, for like hand holding or a hand on the shoulder or a hug. We have to have double consent processes for touch. We think about that in our training programs for EMBARK. And lastly, what about collective care? So what if healing is not just about that one person in that one room, but recognizing that we are all suffering, not just as atomized individuals, but all suffering in the collective in a time in 2024 where there are structural factors that lead towards oppression because of our economic situation, because of all the work that has to be done, because of people not having access to healthcare, people not being empowered in their places of work or in their families. And so how do we talk about that and care for each other collectively? And use that model in the treatment room. What is your experiences with psychedelics? Maybe you have your own personal experiences. Maybe you have tripped with friends. Maybe you're a researcher or a clinician. We want to bring in that real life experience in part because it informs how we think about what it is that we're doing. And with EMBARK, I'm going to go through these 6 clinical domains now. So if you remember, these are the EMBARK domains. I'm going to go through them right now, starting with the E domain. So with EMBARK, we want to center and normalize mystical experiences. There's a lot of research and scholarship about the potency of mystical experiences, predicting reductions in depression. And in the Hopkins work, they've done a lot of work around providing what they call spiritual support. In EMBARK, we wanted to look at that existing scholarship, but we also wanted to think about particular things that could come up for participants. Some participants, when they take DMT in a trial, they experience oceanic boundlessness. They experience a deep sense of unity with all of humanity. They have an experience of awe. They may meet entities in DMT processes, or gods, or angels, or some sort of presence, some sort of guiding spirit. And so it deals with existential themes of mortality, death, meaning. And so in the existential and spiritual domain, we want to pull in evidence-based therapies into the EMBARK approach and techniques from those therapies. So EMBARK it kind of welcomes these evidence-based approaches. It's not a narrow approach, but it's more broad. So we want to bring in, for example, spiritual, existential, religious, and theological CERT integrated psychotherapies. We want to bring in techniques from Miller's work for spiritual evocation. We want to bring in the existing therapy techniques from existential psychotherapies, which was used to some extent in the NYU trials. How can we bring in meaning-centered psychotherapies into this work? We also recognize that the mechanisms of action are not just biological, but they can be psychological. And so we have suggested mechanisms under the E domain. We think that having a mystical experience is a demonstrated mechanism of benefit. And then also this idea of spiritual self-development, that the person actually develops their sense of spiritual or meaningful life over the course of preparation through the end of integration. And so here we have a general approach to that. What about mindfulness? We want to encourage both the therapist and the patient to cultivate awareness of mental processes and to grow in our self-compassion. How do we interrupt, for example, for depression, interrupt rumination? How do we interrupt insertive, depressive, ruminative thoughts? So for mindfulness, we want to cultivate a neutral and non-reactive approach. And we want to develop this capacity even in responding to what happens under the influence of medicine, that we want to be mindful of what arises and treat it with self-compassion. So in the M domain of EMBARK, the M domain, we see, look, this is not a surprise. We see ego death experiences. These sort of phenomena happen that people's sense of self, their ego starts to become loose, and they may even feel that they are dying. And as we dissolve one's ordinary sense of self, there's a feeling of transcendence, a transcendence of rigid ideas about who I am. Our consciousness is not like this thing that's like somewhere between the eyes and an inch back into the head. It's the full sense of that we may merge with the other, we may merge with the room or with nature. And so we want to establish a sense of observer consciousness, and people oftentimes feel mental freedom towards a more flexible identity of who they really are. So in EBT, there's existing approaches, including IFS, mindfulness-based cognitive therapy, MBCT. For depression, we have rumination-focused cognitive behavioral therapy, RFCBT. There's ACT up on top, and even compassion-focused therapy. And so all of these existing therapies use techniques that are about mindfulness and that are fair game to be incorporated thoughtfully and integrated thoughtfully into an adaptation of EMBARK. What about the body? I've already talked a little bit about this. We do want to use a trauma-informed approach to the body as it arises. It's often a blind spot for us that we kind of ignore the body, but it's a site of meaningful events, therapeutically meaningful events. And with psychedelics, people have altered proprioception, a feeling of their internal experience of their body. They have a sense of energy. They may have a sense of heaviness. They may feel more physically embodied and alive. Oftentimes they have strong catharses, strong sense of feeling full release, and that often takes the form of shaking, convulsing, trembling. People may eject things from their bodies. I've had people tell me that multiple times. They may have purgative experiences of gagging or even vomiting. And so in the body aware domain of EMBARK, we want the clinician to be aware of the body and to have some basic competency with somatic practices, including drawing from maybe their existing training in Hakomi or sensory motor therapy or Pete Levine's work with somatic experiencing. And, this is not, look, it may take a lifetime to become an expert in somatic processing and somatic techniques. But in EMBARK, if you buy the book, for example, there are certain techniques like penduluming, where people can pendulum in while they're 2 hours into a psychedelic experience. Pendulum into a feeling of like intensity or fear. They're like confronting, they're moving towards something that makes them seize up and really get scared in their body and get rigid. And then pendulum, and when they can't tolerate that anymore, we encourage them to take a breath and to pendulum back out. And pendulum out of the intensity into a place of resourcing, centering, grounding, breathing, self-regulating. We can co-regulate with them as therapists. And take a few minutes to come out. That may mean like taking your eye shades off and talking with your therapy team. And then when you're ready, putting your eye shades back on and penduluming back in. And so this is a very basic grounding somatic technique that can be useful rather than just telling people steer for the deep water, do the hard thing, like approach the monster. That may not be helpful for some people because they can get dysregulated and overly dysregulated in work. So we want to use penduluming, for example, as a somatic technique. In the A domain for EMBARK, and I want to be clear about this, for one participant, they may have the E domain may be emergent, and these other domains may not be that important. For one participant, maybe the affective and cognitive domain is really emergent, and that's what you work on as a clinician in integration. So we want to identify affects. We want to identify feelings and welcome those feelings, not run away from them or avoid them. We want to deepen our affective states, including negative feelings, fear, rage, grief, and how those, and the way that we haven't felt those contribute to self-beliefs and to our depression. So depression is often about avoidance of challenging affect. People do not want to feel their grief, and so they stay in a dysphoric, dysthymic place of sadness. And so in the A domain, people, I once asked a person, like, what did you feel? And they said, I felt all the feelings I have ever felt in my entire life. And so in effective cognitive work, we pull in techniques from emotion-focused therapy. We can pull in techniques from ACT. We can pull in emotion-focused work from psychodynamic and affect phobia therapy. And this helps the person to transform their feelings and to update their core schema or their core beliefs, including accepting their emotions. Oftentimes people are so angry, but they haven't allowed themselves to feel angry. In the R domain for EMBARK, we're rounding the bend. This is 5 out of 6 domains. This is about human relationships. When people are depressed, they are often isolated and alone. We want to reduce isolative behavior, not both in the psychedelic therapy session, but also and over the course of their work. We want people to have human relationships. They want to be connected. And so there's an opportunity for relational repatterning with their therapists. And we read about this in the book. So psychedelic therapy is deeply relational, even when people say it's an inward-focused work. I have to tell you, sometimes people talk about the medicine session or the drug administration session. You have prep sessions beforehand, the drug administration session, and then integration sessions afterward. In the psychedelic, when you give the person the drug, sometimes they don't think of that as therapy. They just like, okay, now we're just giving you a drug and you're doing your own work. But that is not how it actually works. The person takes the medicine and then they're doing therapy throughout the entire day with their therapy team. They're taking their eye shades off, their headphones off. They're talking to people. They're doing therapy. They may be under the influence of the medicine, but it's deeply relational. It's not like you just give someone the pill and they go off on their own. We see that sometimes in ketamine work, where you have anesthesiologists who aren't known for their bedside manner, anesthesiologists and anesthetic nurses who just give person the ketamine and they put them in a dentist chair and they close the door and they're alone. That is a model. It is not the normal model in psychedelic therapy. The work is relational. And so there's benefit and potential harm here, and we have to attend to this. A lot of the research suggests that the relationship is crucial. I have a link here to our work about that. And I want to say in the R domain, we bring in relational dynamic approaches and techniques. We talk about attachment and attachment style if that's relevant. And if it's relevant to if someone's anxious or avoidant or disorganized, we think about that. We do parts work and IFS work. All of that is potentially useful approaches. We don't try to do all of this, but if it's emergent for that participant, we may lean into that, and the manual allows for an open architecture. If you're a clinician in an EMBARK trial, we encourage you to sit on your cushion. It's really important that when you're a clinician in the room that you remain calm, unhurried, supportive, human, not robotic, impeccably boundaried, open, and that last N should be non-judgmental. So it's important that we co-regulate with participants, and so we sit on our cushion. And this is a reminder that, like, when things start to get hairy, difficult, or challenging, the therapist also has to downregulate, like not get anxious, not get panicky. If the person feels really scared, the therapist's role is to remain calm and supportive and sit on their cushion. And we also want to avoid frazzle. There's an English word. Frazzle is like when things get crazy and hairy and difficult. When your hair gets like all out of alignment. So we want to avoid being frantic. We want to avoid being rigid in what we think should happen. We want to avoid, as clinicians, being artificial. We want to avoid being zoned out. We want to avoid being therapeutically zealous, like it has to happen one particular way. We don't want to be loosely boundaried, and we don't want to be exhausted. It's important to get sleep and nourishment for yourself before doing this kind of work, so that you are nourished and rested. All of that's in the relational domain. And the sixth and final domain here, and I'll pause in about 5 minutes for questions and discussion, is the keeping momentum domain. So in a lot of existing clinical trials, there's this idea of relapse prevention. It's fine if the person gets healthy for a day, but what does that look like integrated into their lives? In psychedelic work, people oftentimes have strong motivation to change. They come out of a psilocybin experience and they feel excited. They want to start bicycling. They want to start meditating. They want to make amends with that friend that they had a fight with. They want to be a better parent. They want to change their job. We want to build on this increased motivation to make a plan, to make actual goals, and to enact real life changes that captures lightning in a bottle and takes the momentum that is generated from the psychedelic work and the psychotherapy, and then translate it into the months and years following the session. Sometimes this is aligned with this idea of plasticity or neuroplasticity, that psychedelics open a critical learning window. Well, that's all fine and good. So what do we do with that open window? What do we do with neurons that fire together, wire together? And if psychedelics open new learning so that we can learn new habits, like a new habit could be, instead of being depressively ruminative, I'm going to have a new thought pattern, a new internal habit of being kinder to myself, having more self-compassion. So instead of self-criticism, I'm going to try to have more self-compassion in how I think about myself. So we want to take that window of neuroplasticity and plan for it meaningfully with keeping momentum. People feel more hope, There's a sense of renewal. There's oftentimes a lot of reckoning with one's own problematic behaviors, and people want to revise their life and reconnect. So for keeping momentum, we look to relapse prevention techniques. This includes motivational interviewing. People have a renewed willingness to change, and so we address their ambivalence to change. That could be quitting drinking, quitting alcohol, but it could also be, all sorts of changes in a life, like changing your sleep, stopping smoking, exercising more, or more subtle things like being more creative. And so we have suggested mechanisms that we build the motivation for beneficial new habits and other life changes, and then we integrate that in prep medicine and integration. So I'm really excited about, and I hope that some of this is speaking to you. With EMBARK, we have these 4 cornerstones of care, which I went through before. So there's the 6 domains: EMBARK, existential, mindful, body aware, affective, cognitive, relational, and keeping momentum. And then we provide forms of trauma-informed care, culturally competent care, ethically rigorous care, and collective care. So EMBARK is really the 6 plus the 4, the 6 clinical domains, any one of which or 2 of which might be really emergent for one participant. And we always try to, we bring ethical work right into the psychotherapy. And so for trauma-informed work, it's just so important that we address trauma as it arises and as it may be unleashed with psychedelic work, and be prepared to support people, even if we're not treating PTSD. I spoke about culturally competent care, ethically rigorous care, and our collective care, which acknowledges collective social conditions. And we don't want to pathologize the individual if they don't have a lot of power in their place of work. We may have somebody who is being taken advantage of. Our participant, for example, may be taken advantage of at work, and we may say, you should be more assertive. You should tell your boss, hey, don't treat me like that. But that actually may not be a safe intervention for that person in that context, because they could lose their job. And so we have to be attentive to how not to pathologize the individual as not being assertive enough, when the individual is actually being smart and wise to protect themselves by putting up with bad treatment in order to maintain something that they need, which is economic security. So how do we care for each other collectively and have a criticalist lens? There's this dorky photo of me welcoming a participant at the door. All of this work happens in preparation from the first handshake. And so we have watchwords in EMBARK, and I'm not going to go through this, but this is just in the prep phase for each of the domains, we want to have some watchwords. In the medicine phase, in the middle of the work, when you're sitting with a person and they're taking the medicine, we have watchwords for the medicine session for each of the domains. These are key words that you should keep in mind. So for example, for affective and cognitive work in the medicine session, we want to turn toward experience. We want to deepen, and we want to respect the protectors, the parts of us that are telling us, I'm not ready to go there right now. And then after the medicine session, we do integration work, and we want to think about, in the weeks and months following, how do we integrate this into our lived experience? And so these are, how do we have a new mission statement? How do we repair ruptures that might have happened in the work? What happens when we land into our body in a new way? What happens when we have a new role or a new identity or a new self-concept? I just want to thank and acknowledge that this is not something that I've put together. Bill Brennan is really my dear friend and colleague and primary author of our book together. Also Diane, Alice and Sarah, Melissa, Liz, and Alex Kellman, team at Cybin have done incredible work to put this together. We recognize that none of us are experts in all of this, and so we've brought in faculty and supervisors for the first cohort, including Nicole Buchanan, Kylea Taylor, Jordan Slowshower, Marcella Otalora, Flory St. Amy, Robert Krause, Didi Goldpaw, and Franklin King, Manuela Mishka Reeds, Jeffrey Guss, and Tony Back. We've also been advised by some fantastic folks, including Maurizio Fava, Lynn Marie Morsky, Tony Back, Tom Logren, our friends at Fluence, Ingmar Gorman and Elizabeth Nielsen, John Crystal, Dennis McKenna, Andrew Solomon. If you're interested in EMBARK, we have made the first EMBARK course available free as an open source foundational training in psychedelic therapy. That's available to you, your colleagues, your students online. You just go to embarkapproach.com and click on open access. So this is an open access course. It's 16 hours of trainings with little quizzes afterward that are video recorded by those faculty that I just showed you. We've had over 3,000 people sign up. So it's been very successful so far. Not everybody's finished that, but those are registrants. So feel free to check it out. So you can start that free online course there. We hope that that's helpful to you. And if you're interested in the book, we can talk about questions about EMBARK now. But this is intended as a handbook for clinicians. It's a clinical manual. We hope you'll consider it if you're putting together a curriculum for a college course or a training course for people who are training to become psychedelic facilitators or therapists. We also hope that it will be useful if you're putting together a clinical trial and you're looking to use EMBARK or looking to use a manualized evidence-based therapy. And EMBARK has, I didn't show these data here, but we have preliminary data that I hope will be published in the peer-reviewed literature soon, that an RCT, a randomized controlled trial with EMBARK, shows efficacy in the treatment of depression with a large magnitude effect size. It's also being piloted in Seattle in a different RCT. And so if you're interested in adopting an approach, feel free to use EMBARK. And also we're open to adaptations for different molecules and for different populations to work in. It's really taken a whole village to put this together, and so I'm excited to learn from people as they implement it. So I'm going to go ahead and just conclude. So this is the EMBARK module, and I think if you have questions or comments, feel free to put them in the Q&A, and I'll stop my share here. And I think we can maybe do some Q&A now. So thanks for your time and thanks for listening.
Wow. Thank you, Alex. It seems like a very, very comprehensive model that you've developed, and it's almost, I feel almost like overwhelmed, like by all the, like mastering all the domains seems like a big task. I'm curious on how does one. You mentioned the training. That's apparently it's a free training. You mentioned it in the embarkapproach.com.
Yes, it's free.
So that's a brief education material. How does one train to have like mastery over like all the 6 domains and all that?
Yep. Yeah, it seems like too much, right? It's like, wow, it's too much. I think it's important that we're not aiming for mastery. I mean, I think that it would eventually, yes, of course, we're all aiming to become truly masterful and deeply skillful when we do any kind of work, right? Hopefully we, especially as clinicians, as therapists, as facilitators. But look, you could spend an entire lifetime just developing mastery in mindfulness, or an entire lifetime just developing mastery in somatic practices, or an entire lifetime just developing mastery in motivational interviewing and IFS, or, you know, spiritual counseling. So we're not aiming for mastery. And I think that that's not feasible with all the trainings that are out there. What we are aiming for is for the work to be informed and for some basic competency. So we find that most trainings don't have any somatic training at all, right? Don't have any embodiment training at all, or they don't have any relational training at all about the issue for relational ruptures and relational harm that might happen in the work. We wanted to provide some foundational training, and in the book there's a whole couple of chapters for each of these about what that means. But we want the clinician to have an introduction and some basic competency to be aware of that. So, for example, I'm not a master of working with trauma. I've done PTSD trainings. I still don't. I've done trauma trainings and clinical practice for 10 years. I still don't consider myself a master of trauma. But the work is we provide trauma informed care, so that when it happens, the clinician isn't totally ignorant. I think that really it's like a lot of information, but so we've been teaching this to people. And if you're looking for more advanced training, EMBARK has teamed up with, so EMBARK got funding from Cybin to be used in Cybin's clinical trials. And Cybin's teamed up with Fluence to provide trainings for those clinical trials. And I know that they're doing trainings, and we'll be doing trainings for clinical trials in the future. If you're really looking to get Mastery True, you can buy the book, and feel free to reach out to Bill Brennan and myself. There's not like an open, comprehensive training right now for EMBARK open to the public, but the book, like many psychotherapies, explains as much as we can in writing there. Can I just kind of explain though, like, if you're a therapist, look, you're already doing what you're doing, right? You already have your theoretical modality, you have your own training, you have your patients, you have the work that you do. What we find with EMBARK is that we just, you'll find that like it's actually not all of those things. It's like you're working with a human, and that person has an experience, and so if that experience is like they come in and they say, hey, I really want to like make a change in my life. I want to quit smoking. My goal is to quit smoking. I want to stop, with the medicine session, and I want support afterward. Then that's goal setting, and that's about their motivation for change, and that's about motivational interviewing, that they're in a place of contemplation to change right now. And that's all about the K domain. That's all about keeping momentum. That's all about like using that momentum, and how do you keep that going for months afterwards. So it may be that they don't have a profound existential and spiritual experience, in which case you prepare them for that when you do the consent on the first day. You may say, you may experience this and this and this and this, but they may only have one or two things which are ascendant. And so when you treat 100 patients, there are individual trajectories of healing, right? And so some people get better in different ways, and it's not one size fits all. They don't all get better in the same way. And so EMBARK is sort of open in that way. Any one of these domains may become emergent, and the others may not be important at all. And so it's really patient centered. So you're not saying do this, 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 and this. It's actually what does the participant say, and then work with that. Work with where the patient is at today.
Okay, so makes sense. It's about what is sufficient background knowledge in each domain, and it's about seems like an integrative model of like not having a ready theory that's been followed with the participants, but more like following on what they bring up, or what their experience is. So following the patient and not the theory. Okay.
Yeah.
So please write the questions in the Q&A, and I'll pick the most upvoted ones from there. So we have questions from anonymous attendees, so I'll read them. So first question: can you talk about the practicalities of negotiating consent around touch? Perhaps also about concrete situations where such practices might be needed. And in relation to this, what is double consent that you mentioned?
Yeah. So, look, there's been a crisis in psychedelic medicine for the last few years because of violations around touch. Um, I think there's some very high-profile cases of that, and so we were aware of this beforehand. If you're developing a psychedelic treatment approach, we want to be very thoughtful about what kind of ethical framework we're using. So with EMBARK, Bill Brennan, for example, did his dissertation research on touch boundary violations in underground psychedelic work. And so he's a real expert on the ethics and has served on APA's ethics committee and in other groups, and gives a fantastic talk about exactly this topic. So I'll refer you to Bill Brennan, who's really fantastic about this. And I think Bill, I'm not sure if his talk on this is public. We used in EMBARK, and this is covered in great detail in the book, what we call both enhanced consent and a double consent process. In enhanced consent, we recognize, well, first of all, double consent is the idea that whether you're in a clinical trial or in the community practice, you want to tell a person, you want them to have informed consent. So you explain to them what might happen under the psychedelic experience as best as we can. And we talk about specifically what kind of touch they may want. Now, I believe, and the leaders in psychedelic medicine across the board consistently say that actually not having any touch at all in a psychedelic trial is potentially harmful, because people sometimes feel really scared and they would like to have a handhold, for example. Or it's very strange if your participant comes in the room and you don't shake their hand. Or if somebody asks for a hug and you say, "I can't touch you." That's your choice as a clinician. If you don't want to give a hug, that's fine. But we're really clear. Certain forms of touch are potentially permissible if all parties consent to it. So, for example, we allow for sitting hugs. We allow for people to sit next to each other on the couch and even to put an arm on the shoulder in a supportive touch. If the person asks for it, we can initiate, or they can initiate holding hands. And I've done a ketamine session with a participant where I know her very well. She was scared and she asked if she could hold my hand. And we held hands for an entire hour. I just sat next to her and held her hand. I didn't say anything. She was just in her own process. So the double consent is we do that at the beginning, when no one's taken the medicine. And so if the participant says, "You know what, I don't really want hugs or arms on the shoulder. I just want to be able to have a handhold if I ask for it," then that is all that's allowed in the actual medicine experience. Then next week, when you come in for the medicine experience and they've taken the medicine, we may review what they've said. There's a double consent. So the second consent is, they may say, "I'd like to hold hands," and we could say, "Is that okay for you now to hold hands?" Or we may offer, would you like a handhold now? And they may say yes or no. So you don't just touch the person, you actually consent again. We have found that approach centers the autonomy of the participant. It centers their agency. It centers their decision-making capacity. And it's also cognizant that they may feel differently in a psychedelic medicine experience than they felt a week ago, right? So then that person may say, "I really want a big hug." And they said, "Well, last week you said to us that you didn't want a hug. So we're going to hold off on that for now, but we can talk about it tomorrow when we meet for integration." Because sometimes people want to do all sorts of things in the psychedelic room that they will feel shame about the next day. So we want to respect what their sober person said, as well as what the person said that themselves said under the influence of the medicine. So that's kind of what it looks like. And we want to attend to the power asymmetries that the participants, they're in a room, they're in your treatment room, they're with oftentimes two therapists. The therapists have advanced degrees like PhDs or MDs or clinical licensing. And so they may feel that they have to do something. And we certainly want to attend to those power asymmetries in the room and acknowledge them and try to be cognizant of them as much as possible and work to empower the patient to feel like they have agency.
Yeah. That's a great example. Yeah, I'm curious about the use of touch. What do you see as indications or contraindications for touch? Not related to what you mentioned about the consent, but is there other situations where you view it as a necessary or very useful intervention, and when not to use touch?
One way to go about answering your question is to think about it from the clinician's perspective. And Kailea Taylor and Bill Brennan in their own different ways talk about this. Let's say you're a therapist in the room and the participant is having a panic reaction. They're really scared. They're like kind of freaking out. They're obviously terrified. They may even say, I'm having thoughts that I'm being, that this isn't safe. Like, I don't know what's going on. And as the therapist, you notice in your own body, because there's a reflective process, you notice your own thoughts. Like, you get scared, you get anxious, you want to calm them down, you want to assure them that no, it's okay, you're safe. Like, this is a safe place. So suddenly you have very strong needs as a therapist. And so sometimes we see therapists in the room when we look at videotapes, we see them. If we were to ask them, like, why are you doing what you're doing? Are you doing this in the interest of the patient? Are you doing this because so then they go in and say, like, here, come here, like, hold my hand, I'll calm you down. Or like, so there's this idea that the therapist is motivated to allay their own anxiety. And they want to touch the person to calm them down. And they may be well-meaning. They may think, if I just hold their hand, like, and breathe with them, then we'll co-regulate down. And that might work. But if they are not consciously attending to their own need to touch, even if it's, for good purposes, they may cause harm, because the person may shrink from the touch. They may feel like they weren't asked about it. They may not have initiated the touch. And so, for contraindications to your question for touch, the training and the book really encourages a therapeutic self-reflective practice to look at why are you doing what you're doing? Why do you want to say this, not say this? Why do you want to move further? Why do you want to move closer? Why do you want to go to the bathroom? Why do you want to, like, give them a juice drink? Like, what is going on for you in the room? I think that for people with histories of sexual abuse in their childhood by parents, family members, by dates, experiences of sexual trauma, we should be very, very thoughtful about touch, and also about therapist pairings, right? So that the gender of the perpetrator, is considered when making an assignment of the therapist to the participant. So histories of sexual violence should be certainly considered. But honestly, the best thing that we found is just talking about it really openly, like in the first few preparatory meetings, to say, like, hey, let's talk about better uses of touch, and like what you feel comfortable with and what you'd like to not have. And some people are like, yes, definitely, I love hugs, that would be really helpful to me. And some people are like, you know what, I'm okay on the couch, I'm glad that we talked about it, thank you for talking with me. We want that participant to be a co-author, right? That they're in charge as much as possible.
Great. Then next question, we have again an anonymous attendee asking about burnout. You mentioned it in your talk. Has there been research on treating burnout with psychedelics? How would one go about doing it?
Well, I want to acknowledge and thank Dr. Anthony Back, B-A-C-K. So he's a physician in Seattle at the University of Washington, and he created with us the first adaptation of EMBARK for his randomized controlled trial of treating burnout. So this is a trial after the COVID pandemic to treat doctors, nurses, and frontline healthcare personnel in hospitals and clinics who are experiencing symptoms of depression and burnout and what we call moral injury, which is burnout is about like the individual's experience of exhaustion in the face of systemic failure. Moral injury is their feelings of grief and anger and marginalization when the system of healthcare, like in the COVID pandemic, has failed them. Right, when they are injured morally, that we should have better healthcare. I'll speak for the United States because I know the United States. We should have better healthcare. We should have better respect for clinicians from the administrators, better pay, better benefits. There should be better treatment for patients and from patients. People are spitting on each other. Terrible things are happening. Everyone's wearing masks. There's no support. It's just like it's like a war zone. So people feel moral injury. And Dr. Back has not come out with his findings, final peer-reviewed findings yet, but he has talked about his trial publicly in Denver at the Psychedelic Science Conference, and it's really exciting. He enrolled 30 doctors and nurses and professionals in the trial, treated with psilocybin and EMBARK to treat symptoms of depression and burnout. And I'm looking forward to his results when his team's results come out. So yeah, I think that it's really powerful to treat burnout, and there's been a real focus on caring for the caregivers and the issues of burnout in the community. I'm a consultant for a group called Healing Hearts, Changing Minds. I don't think I listed them in my disclosure, I now realize, but Healing Hearts, Changing Minds is a philanthropic group that is funding research into training for LGBTQ, lesbian, gay, bisexual, transgender, queer people as patients and as trainees. And they're hosting a meeting for clinicians who feel burnout. You know, how do we care for the caregivers in a time when so many people in hospitals and clinics are just under-resourced? Yeah.
How does that work researching burnout? I'm not familiar that, because usually it needs to be in the like diagnostic manuals, the sort of indications that are being researched. So in case of burnout, is it like is it under the diagnosis of depression, or how does it work?
I think in Dr. Back's trial, he used symptoms of depression. It's problematic, at least in the United States, I won't speak for his team, but my understanding is that it's problematic to give doctors and therapists and nurses a diagnosis, because it could be difficult for them with their boards, or it could impair put at some jeopardy their working. You're right. It doesn't abide by either the DSM or the ICD-11 sort of set of diagnostic codes in that nosology, nor does it abide by like an RDoC framework for like underlying research domains criteria. That being said, it doesn't mean it's not real. And there are, the construct of burnout is a real construct. There are, I forget the Maslick. I'm having a moment. I don't remember the name of the measure right now, but there are very validated measurement scales for burnout. It's unlikely to become an regulatory approved by the EMA or by the FDA or the MHRA indication, because my understanding from regulators is that they are more interested in improving something either in the DSM frame or the RDoC frame. But it may be helpful in such an event as MDMA. Let's say MDMA is approved or psilocybin is approved. It could be used off-label. It's approved for depression or it's approved for PTSD, but potentially there's a use case for it to be used off-label for other indications, including burnout. We know that in a lot of psychedelic trainings, a lot of people are getting ketamine-assisted therapy, right? And they have to have a diagnosis of anxiety or depression. But if they had burnout, maybe they wouldn't have to be diagnosed with depression or anxiety in order to be prescribed ketamine legally, in order to have the training experience of having an experiential training with the same medicine that they're administering. So that's my understanding.
Yeah. Okay. Then next question, again anonymous. In a recent Finnish study by Moliner et al., it was shown in animal models that the antidepressant and plasticity-inducing effects of LSD and psilocin are independent of the serotonin 2A receptor that is relevant to much of the typical mind-altering effects, instead working through the TRKB receptor, the receptor for BDNF. What are your thoughts regarding the ongoing debate regarding how relevant the experiential aspects facilitated by psychedelics are to therapeutic outcomes?
First of all, for all of my neuroimaging, psychopharmacologists, psychiatry, friends, I think it's fascinating. Is it TRKB? Is it 5-HT2A? Like, what are the specific mechanisms? And exactly, let's tease that out over time. But two, so first of all, we don't know yet exactly what's important, or maybe they're both important. There's, as far as I know, no meaningful research whatsoever that having psychedelics without psychedelic experiences have any therapeutic value at all. Like I went to it was interesting, like in the ketamine world, where BDNF is also important, there's this idea that's like, let's give ketamine at a low enough dose so that people don't have dissociative effects, which are seen as unwanted, because we don't want to provide therapy or support. We don't want people to trip. We just want to give them 6 sessions of a low dose over 2 weeks so that they get enough medicine in the body over time to have a medical antidepressant effect. And there's maybe some evidence that that kind of works. However, I think that in all of the psilocybin, what's interesting with ketamine is that the best biomarker for treatment efficacy is dissociation. So the very thing that people are trying to avoid, which is actually psychedelic effect, the psychedelic effect, the dissociative effect, these are all semantics, really. I know that they're slightly differently constructed, but is exactly the thing that is probably, I believe, causing benefit. Look, this is an empirical question. All we have, we don't have a randomized controlled trial where we give a person a high dose psychedelic, but also induce let's say we could induce a coma, like a medical induced coma, so that they get a high dose of LSD, but they actually have no effects, right? They're just asleep for it the whole time because they're anesthetized. And then do they get better? Do they have less anxiety, less depression, less substance use? If that kind of trial is possible, let's see. But I will tell you, I don't think that that's possible. You might have some benefit. There might be some medical benefit, but the psychiatric and psychological mechanisms of action, all the senior teachers, all of the patients that we talk to, talk about how important the therapeutic relationship is. And I think that you will be very disappointed if you just try to give people medicine and no therapy, or just try to give, and I have an entire talk about this, like why we think psychotherapy is important, why we think the human connection is important. It's a difficult topic to study empirically. Lastly, I'll just say TRKB, BDNF versus 5-HT2A, serotonin, etc. Any theory of how, like if you ask, how do psychedelics work? And you say, oh, it's TRKB and BDNF, and that causes neuroplasticity. Like, it has very little explanatory power. We actually have, that's not how people think about it. It's like an interesting idea, but until it actually means something, and it's probably complementary, yes, all of that can be true, but it also may be that the person had a huge cry because their mother died and they are grieving their mother, and they've been stuck in a place where they feel alone in the world. and they feel connected to themselves and to their therapy team and to their best friend. And so there's this complex psychological trajectory that yes, may be complementary to the neurobiological substrate. And I think it's possible that all of this is happening at the same time. And we're just talking about different levels of analysis.
Yeah, truly. Okay, we still have time for a few more questions. Nobody wants to ask this themselves, so I'll keep reading. Anonymous attendee asks, how much solid experimental evidence for a model can there be for a model that's so wide and flexible and, as mentioned, that follows the patient's experience as is and is in a very much improvisatory, also probably leaning considerably on the tacit knowledge of the professionals?
Yeah, excellent question. And I agree. It's something that we would like to study. And as a clinical trial methodologist, we do intense ratings of therapy adherence and fidelity to the manual. So for each session, we have videotape and we watch people, and we score them to whether or not they actually abide by the clinical therapy manual for EMBARK. But that is both limited. I mean, that's best practice in the field right now. But I think I would challenge you to think about the question. The concern is that the model is so wide and so flexible that, like, what does it mean? But psychedelics, if you're asking what therapy should we use for psychedelics are non-specific amplifiers of consciousness process. And as non-specific amplifiers, they amplify all of human conscious awareness. And so if you asked 1,000 people what happened in your psychedelic experience, people have 1,000 different things. And yes, there may be different themes that emerge out of that. But so when you develop a therapy to support meaningfully in an integral way a psychedelic experience, it's not one thing that leads. It's not a train track that's like do. It's like the brain. It's like a nested. It's like this logo here. It's branching experiences, and so the psychotherapy has to be open. The therapy like EMBARK has to be wide and open to support that particular individual's that particular patient's trajectory. And so if that is relational, then we work to support that. If that is spiritual, we work to support that. If that is embodied, we work to support that. And then we use fidelity and adherence to track that and say, hey, if it's in that domain, did they do what we're supposed to do in that domain? I think that etiologically and from a research perspective, that is very challenging. And it's hard for us to track our minds around when normally we have a very constricted and narrow understanding. Like if you're doing cognitive therapy for depression, you have a very specific idea of, like, you were telling the person you're having automatic thoughts. We're going to interrupt those automatic thoughts and replace them with new thoughts. Here's an automatic thought record. It's very, and that is clinically efficacious. But it's not going to work for psychedelics. They're non-specific amplifiers. So that's my challenge. And I think it's really the challenge for all of us in the field. I think that what I have found, and what you may find when talking with clinicians, is that in some of these other approaches, they feel like they're a little handcuffed. They're a little constrained, that they have to do a very particular thing. And the therapists don't like it. And the patient doesn't like it, because it's like, okay, and now we're opening up to session 5. We have to do exactly this exercise. And the patient is like, that's not what's going on for me. And the participant, and the therapist may feel like they resent that they have a constricted and narrow theoretical approach to change. So it is a challenge. That being said, the EMBARK book it's undergone scrutiny from 6 peer reviewers as part of the Oxford's publishing process. We've published on it in the peer-reviewed literature before. I think it's defensible, open architecture, and I hope that I hope it's borne out in the research as well in the years ahead. But we'll see. And you know what? And if it doesn't work, or if it's too open, we may have to revisit the model. Yeah.
Hmm. Yeah. So you have manualized the treatment. I guess that's kind of mandatory when doing randomized controlled trials.
Well, you'd think it would be mandatory, but more than half of the psychedelic clinical trials
Yeah.
didn't have a manual. They just said we gave the person this dosage of the medicine and supportive therapy or something, or support or psychological support, but didn't really explain what that was or what if it was manualized. So a lot of people don't.
Yeah. Yeah. My understanding about the manualization of therapies is that it's more like a research indicated by doing research, and not so much as a manual instructing on how to do good therapy. Um, would you have manualized the model if there was no need for doing randomized controlled trials?
Well, I think I think a bad manual is really just about the clinical trial and has no bearing on what would actually happen in the practice room or in the community in real life. I think a good manual, and there are many good manuals out there, would work in both the artificial setting of a controlled trial, a randomized controlled trial in the clinic, but also would work in your private practice or would work in the community setting. And there are some really good manuals out there. And we endeavored in writing the book to have something that could be, we have a much shorter manual for the clinical trials that's about providing psychedelic support. But the book is much broader and is about different, bigger contexts, like real world applications. Yeah.
Mm-hmm. Yeah, I'm really looking forward for the book. It's coming in April, did you say?
Yes, and you can pre-order now.
Okay, great. Henry, you have a question. Would you like to ask it yourself?
Sure, yeah. Thanks for the fascinating talk, Alex. So Jules Evans is running the Challenging Psychedelic Experiences project. And one of the questions he's been raising constantly is that, considering how much anecdotes there are related to negative or very challenging experiences triggered by psychedelics, why aren't more researchers studying the negative effects and risks of psychedelics? For example, traumatic experiences, HPPD, so hallucinogen persisting perception disorder, and extended periods of derealization after the experiences, etc. What do you think are the most likely explanations for the lack of such research?
Yeah, I appreciate Jules's work with the Challenging Psychedelic Experiences project. I think this is critical. I will say, in our first paper, it was a qualitative paper for our participants in NYU in New York. We highlighted this quite directly. We talked about that more than half of our participants in the cancer anxiety trial had difficult, challenging experiences of transient fear, grief, paranoia. And so we talked about the bad trip or the difficult experience, the challenging experience directly there. And that's, I think, still the most widely cited qualitative paper in psychedelics, in part because we really wanted to address that and not sweep it under the rug. I think that there is a discourse in the field that some people use, that the psychedelics are a panacea. They're going to fix a lot of things. They're very powerful. And yeah, some bad things can happen, but only if you don't provide good context. And so it's an easy story that they are a panacea, that they're a cure-all, and it's easy to ignore the difficult experiences. But I don't think we should do that. I think that there's also systematic incentives for everybody doing research to minimize those sorts of experiences, and that's a problem in all research. If you're an academic researcher or an industry researcher and you do a trial, you are mandated to report adverse events and serious adverse events, things like when people go to a hospital. And sometimes the regulators may require long-form follow-ups for things like derealization, or multiple months of they may require like a safety data set. You have to have enough people that have received the medicine and make sure that they are safe over time. But there's not really like lots of extra status or publication or money if you focus on the difficult aspects of this. And I think that we see this not just in psychedelics, but in the field of like meditation. Most people are like, meditation's great, it does all these great things. And then there's like one or two researchers that really make a living focusing on the negative aspects. And I think that this is a real problem with the field. Lack of transparency is going to be, look, I think most scholars are doing really just good work and work with integrity, but we need to correct the perverse incentives that don't require in publishing us to actually give full-fledged accounts of what the adverse and serious adverse events are. We should probably have secondary review of adverse events so that when medical or psychiatric events happen, we can actually understand what they look like and how to interpret them, and not just necessarily rely on the internal team to address them. Psychedelics are very powerful, and people will have difficult experiences. I believe that it's still worth it on the whole, but it's worth it only if you provide sufficient support from highly credentialed and skilled people. And if you start to whittle that down, and the quality of the service that's provided starts to become less and less and less, the potential for risk, for harm, increases. So we need to watch out for that.
I have a continuing question on that. How do you balance the credentials of the clinicians or facilitators? How do you balance that with availability of psychedelic-assisted therapies? Because that's kind of, especially, or at least in Finland now, it's becoming a problem that there's much higher need for psychotherapy services compared to how many psychotherapists there are. Yeah. How do you see the balancing of this?
I have a few thoughts. First of all, there's a deep need for brain surgeons. People have brain cancers all the time, and we need highly specialized people that have gone to medical school, that have, trained with existing surgeons, that have experience doing the surgery, and didn't just see one, do one, teach one, like in medical school, but are really expert in opening up the human brain and cutting out cancers. But you know what? If there's not enough brain surgeons, let's just let the gardener do it. Or let's just let, like the person who is doing the plumbing do it. Or let's just let somebody who's a social worker, or me, why don't I do it? I'm a psychologist. I know about the brain. I've seen pictures of it. I'm not a medical person or a surgeon, but I'll go to a weekend training and open up your brain and take the cancer out. It makes no sense to me. So the question of scalability is a huge crisis. It's not just in Finland or in Europe. In the United States, we have a estimated shortage of tens of thousands of psychotherapists, psychologists, clinical social workers, counselors, psychiatrists, prescribers, family medicine doctors. There's a shortage across the board. And we can have a critique of the guild, and there's not enough schools and not enough funding, and there's all sorts of systemic reasons why there's not enough providers. But I'm very cautious about calls to have psychedelic therapy administered by people with no credentials, low credentials, very little experience, who aren't trained in therapy. I think that this might be fine for many people. So for example, again, if you have 100 patients, maybe 4 out of 5, maybe 80% would do pretty well without much risk or harm. If you just give them the psychedelic psilocybin and give them very minimal support, and they just get support from peers. And I'm a big supporter of peer support. I worked on a company where we did peer support. Like I think peers who don't have specialized training but just minimal training can be really helpful. And that sort of task shifting from the WHO from higher credentialed, higher trained people to lower trained people is important. But if you had, but maybe 80 people out of 100 don't need a psychologist, a PhD psychologist in the room with them. But some people will need that. And until we understand how to triage people who need additional work, I mean, maybe people with severe pathology, maybe people with underlying personological disorders or complex trauma, maybe people with greater life stress or physical comorbidities, maybe they need more support or they need a higher level of training. I'm very worried that you get like a 15-hour training and then you're good to go, or you get a 15-hour training and you're not a licensed therapist and you're good to go. And we've seen that, right? We've seen that in the underground world where people have very little training and harm happens. I don't think that's appropriate.
Mm-hmm. We only have like 5 minutes left, so maybe I'll ask the last question. If it's about MDMA therapy, so if MDMA therapy is approved in the US in the near future, how do you envision the actuality of integrating it with the mental health system in the next 5 to 10 years? What are your expectations, hopes, worries?
So I just got back from Boston. I was speaking at Harvard Medical School, and I had a drink with Rick Doblin, who's the head of MAPS, and they were celebrating that night this really good news. In the United States, MAPS, now Lykos, pre-negotiated with the FDA, the Food and Drug Administration. They pre-negotiated what was required in order for the FDA to make a determination as to whether or not MDMA could be approved for the treatment of PTSD, post-traumatic stress disorder. And the FDA had accepted the file, which just means that the FDA says we have all the data that we need to make a determination, and they will make a determination this summer. My understanding is that it seems very likely that they will approve this, although we'll see. I think it's very likely that we will have legal MDMA in the United States within the next year. In the next 5 to 10 years, look, psychedelic medicine, the mental health care infrastructure and the medical infrastructure and the payer infrastructure in the United States and in Europe and around the world was not designed for psychedelic medicine. It was designed for other treatments. It was designed, for example, for SSRIs and SNRIs. So it's going to be a challenge. What I would hope for, I'll tell you what I fear first. I do fear that we will see translational research, as it comes out of the clinical trials and into the community. We will see efficacy rates decrease. We will see effectiveness rates decrease. We will have I fear that there will be stories of harm, or that we will have people who are insufficiently trained and insufficiently credentialed and qualified doing work. And that really worries me. I hope, having worked with MDMA, that the beauty of this medicine, and having done MDMA-assisted therapy, the beauty of this treatment is that the epidemic of trauma and PTSD from combat, from the wars in Iraq and Afghanistan, and from car crashes and from violence around the world and in our lives, that the ongoing trauma, that this medicine and this approach is highly efficacious in treating it. 2/3 of people who are given MDMA-assisted therapy, after a year after treatment, 2/3, 67%, no longer met criteria for PTSD. It's a notoriously difficult thing to treat. I also hope, so I'm really hopeful about that. I think this is a beautiful medicine. I hope that there are off-label uses for it, for depression, anxiety, other forms of indication. I also hope that there is more community-based, collective ownership of the process, so that it's not big clinics that hire clinicians that don't own the practice. I think that better My sense is that better clinical work happens when clinicians are owners of the practice, are meaningfully invested in it. And in nationalized and socialized healthcare systems, I hope that the national health providers in Northern Europe and in Europe do the pharmacoeconomic analysis and see that it may be more expensive upfront to do the psychedelic work because you have to pay for a longer treatment and you have to pay for a proprietary drug and you have to pay therapists a salary. But it has more durable benefit over time. So it's again preventative medicine. You make an upfront investment that it's more expensive than Lexapro, or than escitalopram, which is cheap as water. But it has benefit for the individual, for their family, for their places of employment, and for the broader collective over time. And my sense is that the payers in Europe understand that better than many of the payers in the United States, which are incentivized in a different way. So I'm really hopeful for this. Look, I have lived my entire life under the drug war, and you have too, where these substances are Schedule 1, they have no redeeming medical value. If MDMA is approved and it's available in safe and good ways, that's a game changer. And I think, I hope it is the beginning of a gate opening for the thoughtful dissemination of psychedelic medicine in our communities and in our medical practices. Yeah, so I remain hopeful, cautiously hopeful, but still hopeful nevertheless. So I guess that's it. Thank you so much for your questions, everyone, and I really appreciate it.
Good point to end. Thank you for the discussion and the talk. It's been a privilege to have this discussion with such a knowledgeable person as you are, and I'm sure I can say this for the whole audience today. So do you have, Alex, any ending remarks you want to?
Thanks everybody for your time. Keep in good spirits, I hope. Henry and Ika, thank you so much for having me, and I'll see you next time. Take care.